Uh, Good morning, everybody. My previous two speakers, they talk extremely important topic, that is diabetes and obesity. As we all know, the incidence of diabetes is rapidly increasing in our country, and obesity as well. In contrast to those two topics, my topic, that is musculoskeletal disorder, that is not much common. But the important thing is each of us have some experience of administering anesthesia such type of patient, and then we really face lots of problem because they have very difficult to take the airway management, as well as sometimes it becomes difficult to go for the center neuraxial block. They consist of if we see the musculoskeletal disorder, they consist of more than 50 types of problem having different pathogenesis, different management plan, and different outcomes. So broadly, we can say it may be the muscular dystrophy, or it may be the congenital myopathy, or it may be metabolic myopathy in the form of glycogen storage problem or disorders of lipid metabolism. It may be the problem associated with the muscular membrane excitability due to different channels disorders, or it may be some problems like short stature. This short stature can again be like proportionate type of short stature or disproportionate type of short stature. So, apart from that, it may be rheumatoid arthritis, it may be ankylosing spondylitis, and so many problems, which even if I start to enumerate, it may take more than 20 minutes. So it is not possible to cover the entire topic. Therefore, what I have planned to pick up certain problem which I had managed, I have seen during last 30 years of my experience, and some of the experience I would like to share with you, and same time I would like to listen from you what is your experience of handling such type of patient. So let us start with the dwarfism in the parturient. And according to Tyson, when the parturient height is less than 4 feet 10 inches, we call it dwarfism. It can be of two types, which I have already told you, that proportionate type of short stature, when the proportionate between the trunks and the limb ratio is maintained, or it may be achondroplastic, having short limb, or non-achondroplastic, where the trunk is short. So the proportionate dwarfism or non-achondroplastic dwarfism, where the size of abdomen is relatively smaller to the normal individual, when the height as well as the diameter of abdomen is lower than the normal parturient woman. In that situation, what is the main problem? Since the abdomen is small, but fetus is of normal size, so you can imagine the problem. Here, what can happen? Patient really may suffer from cardiorespiratory embarrassment. There may be mechanical diaphragmatic dysfunction because of the upward shift of the fetus. That may lead to really respiratory problem in the advanced pregnancy. Again, there is chances of tachycardia, hypoxia, tachypnea. There is reduction in FRC and reduction in vital capacity. Since because of the presence of the normal fetus, what may happen? There is increased intra-abdominal pressure, and the compression to the aortocaval compression will be much, much severe in such scenario. So what to do when we receive such patient? We must assess the adequacy of respiratory system by, if necessary, do not hesitate to go for ABG or pulmonary function tests. And then in such scenario, assessment of airway and the assessment of the spine is extremely important, because you may not be able to locate the different interspinal gap, or it may be difficult to find out what may be the normal size of the endotracheal tube, or what are the other problems. Here again, always we prefer the center neuraxial block in obstetric patient. Here this is also true, and but the difference between these patient and other patient are that you must go for either continuous technique or graded epidural, because the reasons are very simple. We do not know how much dose will be optimum in this scenario. So by graded epidural we can find out the optimum dose, and accordingly we can avoid the overdosing. Subarachnoid block, it is better to avoid because of the increased risk of neurological damage. Why so? Because in normal parturition, the spinal cord ends at the level of L1 or upper border of L2, but here it may go up to L3 or L4 level. So there is chances of neurological damage, and we must prepare for that. If you are planning for the epidural, whether epidural test dose should be given or not, that is again a controversial topic. But here, if you are planning for that, how much should be the volume? According to Ratner, it is 2 ml lignocaine will be enough to provide adequate detection of the proper placement of the epidural catheter. Now, what are the problems related to upper airway management? You may really face in managing the airway because of the micrognathia, because of the atlanto-odontoid osteoarthritis. So the movement may be restricted. You may difficult to negotiate the laryngoscopy. You may difficult to intubate the patient. Another problem is normal size endotracheal tube may be oversized for that patient, so you have to detect what is the optimum size. Chances of aspiration is here more because of the upward shifting of the gastroesophageal junction. And supine hypotension syndrome is more severe in this scenario. Now, if we talk about the achondroplastic dwarfism, here the abdominal size is normal, so you may not face those problems, but here the problem is something different, like megalocephaly, maxillary hyperplasia, large mandible and large tongue. So chances of difficult airway are much more with achondroplastic type of dwarfism. However, there are certain reports which suggest the airway management is not as difficult as we think. So it can easily be managed, except in one case where Prosil LMA was used for management of upper airway. These patients are more prone to airway obstruction, particularly post-operative sleep apnea. Their thoracic cage may be hypoplastic, their rib may be hypoplasia, so chances of restrictive lung disease we cannot ignore. Chances of cor pulmonale ultimately may lead to respiratory failure. What about the central neuraxial block? Central neuraxial block, we see the vertebral column are usually underdeveloped. So it is difficult to negotiate the needle to find out the proper space. And secondly, there is narrowing of the spinal canal, and there is lumbar hyperlordosis. So it is again difficult to decide what should be the dose of local anesthetic. So again we can plan for graded epidural. They often suffer from various degree of neurological disorder. So before going for central neuraxial block, we must properly assess the neurological system, and we try to evaluate whether there is pre-existing neurological deficit, whether there is any neurogenic claudication, or there is simply asymptomatic spinal stenosis. Whatever is there, you must go for proper documentation so that there should not be any litigation in the post-operative period. Third problem is non-achondroplastic. Here again various type of craniofacial deformities are there which make the airway management difficulty, and there might be some spinal deformity which again create problem for central neuraxial block. Now, how much should be the volume of local anesthetic that we can detect? Of course, by graded epidural, but there are certain reports which suggest about 8 ml of local anesthetic is quite sufficient to provide block up to T4 to T5 level. And if you are planning for CSC, again for the subarachnoid block, usually 1.4 ml of local anesthetic is enough to provide adequate analgesia. Scoliosis. Scoliosis means lateral deviation of the vertebral column. So, what are the problems? It depends when scoliosis develops. If it is the age of the patient is more than 8 when the scoliosis appeared, then it may not be much problem. But if it is below 8 years, then really there may be the problem, because that may affect the development of the lung, that may reduce the number of alveoli, and what will be the ultimate result? That will increase the pulmonary vascular resistance, and patient may develop pulmonary hypertension. If we see such patient, what we observe, the restrictive pattern of pulmonary dysfunction, there is reduction in FRC and VQ mismatch, and finally a patient might be suffering from hypoxemia. Stiff lung leading to increased work of breathing, muscle fatigue may be there, and patient may develop respiratory failure, especially during advanced pregnancy. As patient is suffering from pulmonary hypertension, chances of right ventricular hypertrophy is there, and patient may develop respiratory failure. So, what is the net result? The patient may develop various types of VQ mismatch, hypoxemia, patient may develop respiratory failure, patient may develop right ventricular failure, and they are also more prone to aspiration. Their reflexes are very poor. Laryngeal, pharyngeal and cough reflexes may not be sufficient to prevent the aspiration. Dose requirement, again very difficult to find out because of the abnormal curvature. So, normal dose may be overdosing for that patient or may be underdosing. Because of the abnormal curvature, they may migrate beyond our imagination. So, what we should go, again here, epidural or subarachnoid catheter is preferable to single shot injection, so that we can give the local anesthetic as per the requirement of that patient. But in certain scenario, we cannot go for the central neuraxial block and we have to give general anesthesia, particularly if there is cardiopulmonary decompensation and if there is any difficulty in performing the regional anesthesia. While giving the general anesthesia, we must remember we should not do anything which may further increase the pulmonary vascular resistance, and we should maintain the preload, we should prevent myocardial depression, and we should maintain the SVR so that hemodynamically patient remain stable. Ankylosing spondylitis. Ankylosing spondylitis, it is actually the inflammatory arthropathy which is insidious in origin onset. What actually happened? Inflammation followed by deposition of granulation tissue into the ligament and the joint capsule, and the end result is fibrosis, ossification and ankylosis of the joint. Usually the inflammatory process starts with the sacroiliac joint, may extend upward to involve the costovertebral joint and the spine. The net result is total ossification of interspinous ligament, so it becomes a continuous tubular structure, consists of the bone, nothing in between. So it is very difficult to negotiate the needle, it is limit, and the movement is also 100% restricted. And if it involves the cervical ankylosis, you can imagine the problem of the anesthesiologist. It may also affect the mouth opening by involving the TM joint, and sometimes they also affect the cricoarytenoid joint, leading to dyspnea, hoarseness of voice, and vocal cord fixation. Therefore, in such scenario, radiological assessment is very important to find out the flexion and extension of the neck so that we can plan for our airway management. Awake fiber optic intubation is the standard technique for such scenario, but you can plan for a Procil LMA, but sometimes it is again very difficult to negotiate because of the flexion deformity. They also affect the intimatal layer of the aorta, leading to aortitis and aortic regurgitation. There might be different types of conduction defect, may lead to complete heartburn. Spinal cord compression may be there, and features of cauda equina syndrome may be present, and there might be some features of vertebrovesicular insufficiency. Anyway, subarachnoid block is quite satisfactory alternative to the general anesthesia, provided you can reach that place, and technically sometimes it's very, very difficult because there is nothing but the bone. So lateral approach may be better than the midline approach, and if it is necessary to give general anesthesia, then you must prepare with all the equipment with difficult airway. If you are planning for general anesthesia, be prepared for post-operative ventilation because the chest wall is very rigid, it is unable to expand properly, and that may lead to pulmonary complication. And because of the rigidity of the chest wall, if something adverse thing occur like cardiac arrest, even cardiac massage may be ineffective. Rheumatoid arthritis. Rheumatoid arthritis, it is an autoimmune connective tissue disorder. It's primarily involved the joint with having widespread systemic effects. Again, the problem starts with the inflammation, leads to fibrosis, joint destruction, and finally there is deformed cervical joint, TM joint, and cricoarytenoid joint.
Another 2 minutes, ma'am.
Okay. There might be immobile vocal cords leading to airway obstruction. And if you critically examine the pulmonary system, you may see the patient is suffering from interstitial fibrosis leading to restrictive type of lung disease. Patient might be having pleural effusion, pericardial effusion, endocarditis. 25% patients suffer from renal failure. There might be peripheral neuropathy, and the chances of atlantoaxial subluxation. So what I mean to say, each and every system is affected because of this pathology. So what to do? We have to go for proper radiological investigation for cervical spine, atlantoaxial subluxation. We have to exclude the subaxial subluxation. Since these patients are very prone to subluxation, it is always better to go for planned awake fiber optic intubation along with the application of the collar, so that there will not be much movement at that level, and so that there will not be further neurological complication. LMA can be used, but sometimes it is difficult to place because of the deformity of the neck. So these are some of the problems which I have shared with you. I have intentionally not mentioned about the muscular dystrophy because I have never seen such patient in obstetric patient. If you have any experience, I would like to hear from you. To conclude these problems, I would like again to say that the musculoskeletal disorder in obstetric patient having different etiopathogenesis, Naturally, they have different management strategy, but the common thing among all those deformities are mostly they affect the vertebral column at different level, they affect the TM joint and make the airway maintenance is quite challenging. Here, not only the airway management but the central neuraxial block is again very difficult to go for. Restrictive lung disease is another problem. So these patients may go in post-operative respiratory failure, and they usually, that is a multi-organ disease, so proper pre-operative assessment and optimization is essential for proper optimum outcome. So I would like to conclude with the session, with this my lecture, with saying the common principle of anesthesia, that proper assessment, optimize it, the patient as per their clinical situation, take proper informed consent and practice safe anesthesia. Thank you. Thank you very much.